Well, hello everyone. Welcome to today's webinar titled Bringing Advanced Energy to Endoscopic Submucosal Dissection. My name is Ryan Brennan, and I manage the commercial operations here for Creo Medical in the USA. I'll be today's moderator. For those of you who are unaware, Creo is a UK-based company that was founded in 2003 as Micro-Oncology by Professor Chris Hancock. Initially, it was to target the treatment of cancers through the use of high-frequency microwave energy. Creo has recently launched the Chroma Advanced Energy Platform, which combines microwave and bipolar radiofrequency energy to enable a range of miniature endoscopic devices to precisely cut, coagulate, ablate. And so today's talk will include information about the speedboat devices used for ESD. We would also like to thank the ASGE for the corporate partnership and support. Before I get started, I'd like to go over a couple of items just so you know how to participate in today's event. Your microphones will be muted. However, you'll have the opportunity to submit text questions to today's presenters by typing your questions in the questions pane of the control panel to your right-hand side. You may send your questions at any time, but we will address as many of these questions during the video presentations portion of this webinar. I would now like and have the pleasure of introducing our presenters, Dr. Noria Fukami. Dr. Noria Fukami is the Director of Therapeutic Endoscopy for the Division of Gastroenterology and Hepatology at the Mayo Clinic in Arizona. Dr. Fukami is also the Program Director for the Advanced Fellowship, Advanced Endoscopy Fellowship. And also we have Dr. Zach Siamoulis. Zach is the Endoscopy Clinical Director, Consultant Gastroenterologist at East Kent University Hospital and Trust. The agenda today is to have an overview of ESD and its role in the U.S., selecting the right patients for treatment. We will also briefly talk about advanced energy modalities, including the speedboat device. We will then jump into a clinical case reviews with our two experts. And with that, Dr. Fukami, welcome. I will now turn the mic over to you.
Thank you for joining us today. It's a great honor and pleasure to do this with Dr. Zach Siamoulis. And I have to tell you all that he's the one who taught me how to use the speedboat with his exceptional clinical experience. And I learned great way from him. So thank you, Zach, for your teaching. And it is great to do a session like this today. So my role here for now is discussing about ESD to prime it for you to think about why ESD is needed and how best we can accomplish. I'm sure you all have the experience when you see the lesion, you want to get it out in one piece. And if you couldn't, like this, in piecemeal resection, you end up in hearing that the cautery margin is positive. They don't know what the depth of invasion. They cannot clear if the cancer or high-grade dysplasia is totally removed or not. And that puts a patient to a significant dilemma, whether patient would need a surgery for unknown risk of recurrence, or patient can have a peace of mind to have the surveillance endoscopy and periodical scanning. So the cancer treatment is really critical when you initially treat, and we have to really stage it well to navigate patient through the cancer care. Endoscopic submucosal dissection is a new technique to overcome the shortcoming of EMR. We have been having this limit in size and location, and if the lifting is not available or poor, we sometimes have to abandon mucosal resection. That results in surgical treatment. So this is a really nice additional technique to treat early neoplasm in GI tract. We can remove the variety of sizes, shapes. You know, cancer doesn't come in one round shape. So we have to adapt to the shape of the cancer with a clear margin, just making sure that you have a negative margin to remove this tumor. And the quality of specimen you obtain is just a night and day. Our pathologist really loves to see ESD specimens so that they can really see what the margin, what the depth of invasion, if there's a cancer, how big is the cancer actually is, and we can discuss what's the next step with my colleagues in the multidisciplinary clinic. It is really useful for flat and flat elevated lesion where the snare resection is more challenging. And for that, in the past, CAP EMR was invented, then band EMR came on and negated the need for injection. However, those resection technique is very limited by the size, and the area of the resection is just happened by chance. However, you try to get it the precise resection margin, it's not always possible. So larger lesions, it's especially useful to have this hand curving technique called ESD. The idea has been there from a long time ago. It's 1983. There's a publication of marking and cutting around it and remove with the snare. Actually, this is just the advanced mode of this resection type with negative margin. And initial ESD came in for the gastric cancer resection, and traditionally we removed the incise the marginal side area outside the lesion, and then lift up the submucosa, expand, and cut the submucosal layer to peel this off. So that was the initial idea of ESD, and it really took off to be really popular in many countries where they can find early gastric cancer. And of course, esophageal indication is present for squamous cell carcinoma, Barrett's esophagus, and colorectal lesions. And now expanding to duodenum, whether we should do that at the early stage is questionable, but expert hands, it works well. Variety of knives have been invented from the needle knife at the beginning to the IT knife, became IT2 and sprung up to IT nano. Hook knife, dual knife, actually flex knife became dual knife. TT knife and flush knife, bipolar knife, and IRB, the hybrid knife. Those came on as it needed. You know, location required certain configuration and the features to make it safer. And of course, the scissors are available for difficult locations, or sometimes for the ease of use and safety. This is a slide I borrowed from Professor Tajiri. He's a past president of Japanese Endoscopy, Gastrointestinal Endoscopy Society. This illustrates many components of ESD which supported this complex surgical procedure to be safe and much easier. So multiple scopes have been invented to access the difficult locations, and the water jet became it's almost universal, and it's really helpful to clear the field. Advanced imaging would facilitate the diagnosis, and multiple knives came in with a need wherever they're applying this ESD to make it safer. Hemostatic forceps was developed to maximize the hemostasis to limit the thermal injury to muscle layer. And an electrocautery device had tremendous improvement over the years. And IRB ICC 200 was just an amazing machine. Now it's a biosystem which has multiple settings with a computer chip inside. I'll explain to you a little later. Many types of hood came out to facilitate the procedures, and you have to choose which one is really suitable for the location and indication. Injection solution had multiple variations, and many people have favorites because of the long-lasting solution or just the cost itself. I use my own mixture of the fluid But this really facilitated the expansion of submucosa and hold it so that we can dissect. CO2 insufflation made it a complication much less fearful, and we can really close the perforation without any problem with adverse outcome like having to go to surgery. This is an outcome published by Dr. Saito from National Cancer Center. In overall, EMR has much lower unblocked resection rate for larger lesions, of course, and a lower recurrence rate is seen with the ESD. So there's a benefit. We can get in one piece much more frequently, and we don't leave any tissue behind it. That's given. That's consistently shown. They showed reduced delayed bleeding. However, it's known to take a longer time because of the meticulous procedure. You cannot rush. And the perforation rate was much higher, although this is much easier to take care of. So overall, meta-analysis concurred their findings. Higher unblocked resection rate for various sizes and larger sizes, lower recurrence rate. And they don't really talk about the quality of pathology specimen, but they are much easier to evaluate for invasive cancer and the depth of invasion for predicting a future recurrence. Now, longer operative time is consistently seen, a higher perforation rate is seen. To mitigate one of the problem with the longer procedure time and complications, variety of ESD methods has been developed. And compared to traditional method, creating a small area of the submucosal dissection first and expand as you go. This was really necessary in the colorectal ESD because of the submucosal space. It doesn't expand so much, and it doesn't retain the fluid if you open the mucosa. So I made a mistake many times. I just cut around it first, and then I cannot complete the submucosal dissection easily. So this is a basic technique for colorectal ESD, I would say. And the pocket technique came on. Pocket is different because you completely go around underneath the lesion and dissect the submucosa first after opening up one area. So it's more like create a tunnel and wide cavity underneath the tumor, and then cut the mucosa to take this off. This is really useful for fibrotic lesions because you can really get the tension working within the cavity. All the technique is enhancing tension or counter traction in some way with the expansion of the fluid, space with the fluid, and the pushing with the cap. So this is more to be said as enhancing traction method. Tunneling method is proposed in the esophagus. It makes sense if you go through first, and it may be easier to go right and left. And I do various way in esophagus because I get used to it. But for certain indications, I prefer tunneling method. Especially, I'm doing full circumferential resection of long segment. Tunneling method really works better. To make it safer, traction is really the key. I cannot emphasize enough how important it is to create the tension. And in my editorial in 2013, what I said was, what we want for ESD is a second hand, which surgeon does, pull the tissue. So a variety of accessories been invented, but most common thing is a clip and string and clip and snare. The difference is that clip and snare actually allow you to push and pull. Clip and string is only pull. So you have to be really strategic where you place the clip. I'm hoping that we get this rubber band or traction device. We have a little band, it's commercially available. I haven't been using that much. And there are double scope technique, which can be utilized as well. But don't forget the basics: injection, use of food wisely, and use gravity. Indication-wise, I want to refer to two major papers. I had pleasure of working with experts in the field, Drs. Dragunov, Wang, Othman, and published this clinical practice update. And we listed according to the location of the lesion, esophagus, stomach, and colon, and what type of lesion would be probably considered, should be considered for ESD. European had much more earlier adaptation of ESD because they had curiosity, they had much less regulation, I would say. I may be wrong, Zach, correct me. And then the lesions available for in Italy, there's a gastric cancer, Spain gastric cancer, probably because they smoke as well. So they have published the guideline in 2015. In general, if you want to get the lesion in one piece with adequate margin, if it's a cancer, especially if it's highly suspecting cancer, you should choose ESD. If you choose the EMR, get the margin positive for cancer, you would not know how much you would regret. Other indication, I really love this quote by ESG guideline. ESD can be considered for colorectal lesions that otherwise cannot be optimally and radically removed by snare-based technique. So if you think this is much better, you can just apply it, but you have to have a good reason though. In some areas, I think it's beneficial to use the ESD. I listed two, just for example, multifocal high-grade dysplasia and cancer in long segment Barrett's esophagus. If you have multiple areas you have to remove, I think the ESD is much better choice than EMR. But there's no big comparison study to prove that, unfortunately. ESD has much higher complication rate and stricture rate. For colorectal regions, there have been debate on whether high quality wide field EMR is adequate for most lesions versus ESD is better, or minimally invasive surgery is adequate. Those are three things. We have been consistently arguing that surgery should not be applied to the benign colorectal lesions. It's just there are too many patients going through surgery where endoscopists can take care of those polyps. Now, Zach, do you agree that high quality wide field EMR is adequate? ESD is not needed?
Yes, it's a really it's a long debate that is occurring for the last, I think, 5 to 10 years between East and West. But what I keep from your slide, and I really want to point out, is that whatever technique we apply, either wide field EMR, ESD, or microinvasive surgery, it should be of high quality that will bring to the patient the best benefit.
Right. The EMR training is really needed to make it really high quality, think ahead, what's needed done. It's important to know when not to do EMR or ESD. Knowing that the invasive cancer is present is important. Loss of pit pattern is an important indicator. Depressed area is a good indicator. For the granular type, large nodule tend to have more higher grade of dysplasia or cancer. Non-granular type, wall stiffness. I put one of my patient's picture. This was sent for ESD, and I retroflex. Immediately, I see this really stiffness and wall stiffness here. This was T2, and went for surgery. But you have to be able to examine all aspects of polyp before considering treatment. Now, for advanced imaging, we use a nice classification. Type 3 is the indicator of deeply invasive cancer. It's not 100% specific. So you have to use your judgment when not to do it, when to do it. The GeneT classification stratify type 2 into type A and B. B is more of mucosal cancer, potentially submucosal invasive, but this area is usually indicated for endoscopic therapy than surgical therapy. Type 3 is usually sent for surgery. As you see, Dr. Uraoka published that the nodule is the high-risk area for invasive cancer, and depressed area also tend to harbor cancer as well. I published last year in the Gastrointestinal Endoscopy Clinic of North America, and I kind of argued that this should be the flow chart for the large colorectal lesions. I want you to take a look at it a little later, but the important thing is the first attempt is almost always the best chance. If you fail the first chance, you leave the scar, makes subsequent resection more difficult. So if you're not so sure, you should refer to advanced resection center. If you're comfortable, you decide with advanced imaging and a configuration, and you have to stratify if this is just an adenoma or something that we should worry about, high-grade dysplasia or invasive cancer. And ESD can be utilized for those high-risk patients. Of course, if there's a deeply submucosal invasive cancer, they should go for surgery, not the endoscopic treatment. If the ESD gets much easier, then larger lesion can be taken care of by ESD much more than currently practiced. After the resection, we have to assess the post-resection pathology and then refer any patients who has a high risk of lymph node metastasis. I have to go through really quickly. I'm using too much time. So there are two types of electrocautery system, as you know, monopolar versus bipolar. There's one bipolar knife in the past. It didn't get too popular, but the speedboat actually used a bipolar system. Main difference is that you have to conquer a large area of the human tissue when you're using monopolar. So you have to have a much higher voltage to conquer the resistance. So depending on the contact surface, that you can increase current density and make it more powerful, or sometimes too powerful. That causes charring or cutting too fast, and the control can be a little more difficult. And bipolar may be a much safer device, but we have been using this monopolar with excellence, and we tend to understand how it works. But safer is better. Nowadays, the electrosurgical unit has a computer program that senses the resistance, send off the fixed voltage to doze off automatically when the job is done. So multiple settings have to be understood well when to use it, and what the features and what's the benefit, what's the downside. You have to really understand those differences. Radio frequency versus bipolar and microwave. I think Zach is going to explain a little more, so I'm going to cut short. But the benefit is you can focus those energy into a small area, so that we can cutting much more safer and coagulation more effective. That's just a hope. I'm going to make a final point of training, because in the West, we did not have adequate numbers of gastric cases to train on. So that has been the major issue to acquire skill for ESD. But the steps are pretty similar. You have to build up the cognitive aspect and then practice on it at the non-human cases, and then work slowly into the humans. And the traditional Japanese model probably doesn't work in the West because of the problem. Can we train those people directly to colonic ESD rather than going through the gastric antrum, all this in traditional model? And we have been having an issue with the lack of lesions. We don't see gastric lesion often, so we cannot train them. There are multiple studies that the colorectal ESD shown that colorectal ESD can be achieved without traditional training steps. And this is much more informative. If you tutor initial cases, take over if you have encountered difficulties, supervisor or trainer take over and make it safer and give it back to you. And with that training model, about 20 cases were needed after the animal model training to get competent or proficient, or competent, I should say, in the ESD, in the colon, directly colorectal. So I think we should really take the model into the Western world, because we have much more colorectal lesions to be taken care of. And we're seeing much more faster ESD with a safer profile because of the advancement of technology and techniques. So this is my last slide. I think a tutored clinical ESD is a key after the cognitive training and kinetics training and explant. And we want to see the safer tools for everybody to learn and benefit patients. And we have to keep the quality metrics for sure. So I'll give back to Zach.
Yes, first of all, from my side, I want to really thank you, Norio, for giving me this opportunity to, first of all, to collaborate with you, with your expertise on that field, and also to allow me to share my experience. When I started training on ESD, it was very challenging using the current technology with the monopolar knives, as Norio mentioned, and I used this framework of fan scale, and as we realized, I was mainly found to be a type 3. As the time was passing and I was getting more exposed, but especially with the new technology, that I think now I could really say that I'm between type 1 and type 2. So as we progress on training, the ESD becomes fun, but we need to keep some standards, some principles. We need to follow principles for ESD. We need to respect the submucosa, the holy grail of the bowel, and as you can see, we definitely see the two techniques that Nori mentioned. The EMR, which is easy, practical, and you can perform in a very fast manner. But also there's a great discrepancy in recurrence from 10 to 40%. And there's always a potential risk if you go a bit deeper the vessels, that you may have a risk of delayed bleeding. On the other hand, the ESD, the operation field of ESD is usually it's below the vessels, in the vicinity of the muscle layer, and that's why it makes really challenging to operate within the close to the muscle bed. The current guidelines of the European Society, 2015 or 16, definitely there was a slow adoption of ESD, and as you can see, the guidelines pointed out mainly we should perform ESD on suspicious lesions or with concerning features, and also the lesions that cannot be optimally radically removed by a snare. But if you look at the Japanese guidelines, they actually were more descriptive, and they gave more details about which type of polyp we should remove, and adding some more challenging scenarios like the fibrosis, which is a very common, or recurrence. And very recently, there's a new curriculum which was proposed by the European Society, which incorporates what Nori mentioned from the United States. It's very similar in principle, but the whole goal was to provide a high quality training in ESD, and that is really based on three main domains: on the skill set, on the training, and also on the knowledge and maintenance. So, and there is a rule here that is been recommended, the rule of 20. So you can start 20 cases on an animal model, then another 20 cases observing or even assisting, and then finally to move to the human rectum, since there's no prevalence of gastric cancer in the West, as we all know. And that takes time. It's really time consuming. I mean, you have to dedicate at least 1 or 2 years of your life to actually be competent and proficient on ESD. So I want to emphasize that from the Japanese experience, we learned that the learning experience is a dynamic, it's an ongoing process. You can see very experienced and expert Japanese operators in the time span of 15 years, they managed to improve their block resection, they start removing more advanced cancers, and they become faster when performing ESD by keeping and maintaining a low risk of complications. I'm inclined to use some retraction methods, Norio, and I learned from Dr. Saito about the ESO-clip, which really can significantly shorten the time of the procedure, as well as the sinker or a clip. But I'm very fond of the clip line, which I think that should be used at any stage during the training, so you can give the confidence to any operators. And also, this is a very nice slide because all the operators or ESD operators, they should be very familiar with all the range of complications during the procedure or peri-procedurally. And I like this slide because it's really an excellent example from the Australian group, where they actually describe the type of perforation during EMR. And as you can see clearly on this image, you can see that the type 2 and type 3, they're very common muscle injuries that we encountered during ESD using monopolar knives. So to actually start looking forward and think outside of the box, there is a new advanced energy platform. This is a quite innovative and also intuitive technology, because this contains and comprises the microwave coagulation and the bipolar cut, not only to coagulate vessels, but also to cut the tissue, the submucosal and mucosal tissue. And the fundamental principle of this platform is to apply this energy with a lower voltage, lower power.
Yeah, Zach, that was a great presentation so far. I think the improvement of the ESD in Japanese experience also reflect the improvement of fluid injection, fluid technique, as well as the experience itself. So I think it's technology and is catching up to help us doing safer ESD. Thank you, Zach.
Thank you, Nori, and that's so true, this comment and statement, because there's evolution on all fields. But as you mentioned, the electroquality units and the tools are really the most important factors that actually can help us to move forward. So going back to this slide, just to repeat myself, we have this new platform which actually comprises the microwave to coagulate the vessels and the bipolar to cut and coagulate the vessels. So the microwave technology is usually high frequency of microwaves, which is quite different from the radio frequency which we use for the existing knives. And the bipolar is a radio frequency modality which actually is really limited, because it is really within a very small space we deliver the energy. On the next slide, we can see the first speedboat injection device, which really incorporates all these two modalities. There was always a challenge, I think, in bioengineering to combine and link these modalities. So this is a device which has got two blades, one on the top and one on the lower blade, where actually the cutting activity modality is at the edges of the device. Then we'll have the microwave antenna, which is used for control the coagulation, pre-coagulation or active bleeding. We got also a protected hull, which is below the device, and we have also a needle, which is also surrounded also by a very important modality, which is called the rotation. Now we can describe each modality independently. On the next slide, then you can see the active points where the energy is being delivered. So these device is actually active from the tip to both edges. So you can see the tip is one part of the device. The second compartment of the device is the convex edge, which can be utilized for hooking the tissue, which sometimes is necessary when you cope with fibrotic patches. And the third one is the flat edge of the device. So in different scenarios and different circumstances, when, for example, you want to create a tunnel, then you can use only the tip and the convex edge of the device, or when you have the fibrotic parts, or you want to create the tunnel, which always need a lot of accuracy on when to touch the tissue. And then if you want to do some more speedy cut, then you can actually use all the parts, including the tip, the convex, and the flat part of a device, using usually the in to out approach. So if we see a bit more details, the technology, then you can see on the next slide, the first is the bipolar cut. The bipolar cut is used for to achieve an accurate and precise cut. You can see the arrows. The energy comes from the shaft of the device, and then to the upper blade, goes down to the lower blade, and these are the edges of the active part. You can actually clearly see on the video how we perform a proximal cut of the polyp, and then using only the tip and the convex part. Or when we cut the submucosa, we can use all the parts of the device. Again, in a very slow motion, it is very nicely demonstrated the operation of the tip and the edge. This is a device that can be adjusted in the length, so the operator or the tech or the nurse can adjust the length of the device. So you can use a device as 1.5 millimeters, which is usually the most colorectal monopolar knives, up to 4.4 millimeters, where it is the active part. So when we cannot reach the fibrotic segment, or for some reason there's some difficulty to approach the dissection plane, then you can actually deploy and mold the device out from the channel. Or we can see the bipolar precision cut in action and how we can tackle fibrosis. This is actually from a cecal polyp, and you can see the precision of the speedboat device, how it can cut the submucosal tissue without creating any charring. And what really is helpful is how we manipulate the device, and we can cut below the vessels without causing any damage to the vessels. This is the bipolar cut can provide this precision just below the vessel without even touching the vessel. That really gives to the operator the confidence that he can operate above the muscle layer and below the vessels. On the same lesion, it was a very challenging lesion, I think up to 12 centimeters. In the cecum, as we all know, the muscle layer is very thin, and it's very challenging. So we trying to avoid operate very above the muscle layer, and especially when we have to tackle some fibrotic segment, or in this case, we're trying to isolate the vessel, trying to create a nice space around the vessel. The device is placed on the muscle and very meticulously trying to separate the submucosa from the muscle layer, always checking continuously the so-called, I call it the white line or the blue line, so trying to be on the same level. This bipolar cut, you can see the muscle is really, there's no charring on the muscle layer, and the device is being deployed and retracted accordingly by the nurse, depending on the need of the operation field. This is a very really fibrotic parts, which is I would say we can cut really crispy and without causing any damage to the muscle layer. So the separation of the tissue is very slick and gives again really the confidence to any endoscopist to keep going. And again, with a few short bursts, which is I think one of the key learning points once I learned from my Japanese colleagues to apply the energy to the polyp.
Zach, you showed us really clean, non-charring cutting. It was really slick and clean.
Yes, it's something which I was really impressed when I started using the device. That cleanness that can help you, first of all, to see through the entire lesion, and when is your next step. This is also an additional feature of the device where you can actually rotate. It is one-to-one rotation with controlled either by the endoscopist or by the assistant. And we actually discussed about the microwave coagulation, which actually controls the bleeding. It can also provide some pre-coagulation to vessels. This is a unique modality and very quite new for the gut. It actually it is driven by the design of the device, and you need to apply the energy for more than 6 seconds, up to 10 seconds, which is quite unusual when you use monopolar devices, because more than 1 or 2 seconds max, you may cause a perforation or a serious muscle damage. This is a very slow video. It has been published to Endoscopy last year, which proves all the steps of the tunneling using the speedboat device. Again, on the same polyp, we did have some challenging vessels to pre-coagulate, and in one occasion was a very severe spurting. We have to be familiar, with the complications. This is a very big bundle of vessels with a arteriole and a venule, and we can see we apply the microwave for 10 seconds. In this occasion, I applied 2 sets of 10 seconds, and I think it was not enough. That's why you can see clearly now the spurting of the arteriole. And using this device, which has got, I think, the dimensions, gives you the luxury to tamponate the vessel and then apply the microwave for 10 seconds. To stop the bleeding, I applied it for 3 sets of 10 seconds. And what was really for me surprised, is I couldn't see any muscle injury following that. Again, completion of the cut below the vascular bundle, which proves that there was a sufficient and satisfactory coagulation, controlling the bleeding, and also providing more coagulation. In the next vessel, I was more meticulous, and I applied for longer time. I can see 5 times of 10 seconds quite safely. And I know it's very novel and it's cutting edge to apply so long energy. Norio, how do you feel about this long duration of microwave on a vessel?
Yes, so first time you asked me to do 10 seconds, I was really scared, because the coag we do soft coag couple of seconds at most, quick and coagulate. But this one, slow cooking, I just couldn't get the feeling right until went through a couple of times, and really it doesn't give too much of the char effect. No char effect at all, no thermal effect around the tissue. So it's really focused energy, and you can compress the vessel when you're applying, or you can just touch it and still apply, and it still create hemostasis. So that's a very interesting observation, and it was a pleasantly surprised.
And then that gives me a good path to actually go to the next slide. This is a comparison of the tissue sealing effect between monopolar and microwave. So I would just try to give you this very quickly as an outline of the principle. The soft coagulation, we know, is a radio frequency which causes usually to have rotation of the water molecules. It is time dependent, and we have, because we have the body circuit, we have to have high to overcome the high tissue impedance. So we have to rise the temperature very quickly, and there is a risk of carbonization and dehydration of the tissue. On the other hand, the microwave, as you can see, is 10 watts. We use a different modality. We use microwave frequency, very high frequency, which reflects that we decrease the depth of the penetration to the tissue. It's again time dependent, but because we don't have to overcome the body circuit, then we have very low tissue impedance. We have slow rise of the temperature. We are actually cooking the vessel, and as a result, we have a low risk of carbonization and dehydration. Yeah, we have a needle, which the needle comes from the bottom of the device. It can be retracted. It can be used for irrigation or to balloon the submucosa when it's necessary. I think, you know, you can easily inject some viscous solutions or a dilution of viscous solutions. And the last thing is the hull. The hull is an insulated hull, which it's a metallic hull, which you can lie the hull on the muscle, protecting the muscle during the dissection. As you can see on this video, the operator is very relaxed, so he can have the device slightly more deployed than usually, because he can position the device on the muscle, and with the rotation, you can follow the concavity of the host fold without damaging the muscle layer. So just to recap, all the modalities of the device, they're summarized in this slide. So we have to come into contact to activate and stimulate the energy from the device. We can use the in-to-out approach with sweeping movements, which can speed up the whole ESD. We have to always be parallel to the muscle, and we can apply the microwave from 6 to 10 seconds. So apart from the 6 modalities that the device can cut, can coagulate, can inject, it can rotate, it can insulate, I have found really interesting the point that it provides the stability. So it makes the operator look very skilled. And also with the surgical element, you can tackle any vessels using the tamponade and the compression of the vessels. And going back to Nora's comment and to ESG and to the United States learning curve, I think we have to, all of us, follow the MTS approach, particularly with this advanced energy platform, because if we manage to acquire mentality, create a great team and have the skill set, then we can add mentoring, training, and actually organize and schedule structured user groups. So there's a proposed ESD syllabus which can be endorsed by the new technology. So we can have experts to train the colleagues by using a very small group of people. So we aim for individualized training journey, and then following the training weekend or two, then we can schedule a mentoring process for one-to-one. I think all these guidelines, they're on the same page. For our unpublished study for at East Kent Hospital, we have found that the tunneling and the bridge formation technique really favor the use of the speedboat. So we done an analysis and a linear regression analysis of our first data, and we have found that that the tunneling can be a predictive prediction model to estimate the time of the procedure. It should be more analysis to be conducted, but these are the first results that not only to use the time to estimate the proficiency of the ESD, but also to use the tunneling and the time to predict the time of the procedure. And now there are some examples. I'm going to go very quickly. This is sigmoid LST that was performed under sedation using the tiling and the bridge formation approach. I just want to point out the preservation of the submucosa, which indicates that the upper part of the blade is inactive, so maintaining the whole submucosa texture. And we had very difficult feelings when we performed in the same day one patient with sedation and another patient under GA. There are similar sizes of these polyps, and we think that to streamline the patients to have propofol or heavy sedation or GA or sedation, simple sedation, consedation, that can affect also the outcome. I know it's not in the States an issue, but in UK, for example, we don't have, we cannot accommodate so frequent heavy sedation lists. This is again what Norio mentioned, that we sometimes we have to anticipate the risk of fibrosis. This is a type 2B very sessile polyp and with a pseudodepression, and that was confirmed by the histology. And we encountered the muscle retraction sign, and as you can see, is more prone. It's more easily found to the sessile lesions. And that patient, fortunately, he had the polyp excised, but he has some advanced histological features, which is led to the decision to operate the patient. But because of the advanced age, the patient decided to opt for endoscopy. And this is I think this is, and that's why we managed to excise that using the transanal submucosal endoscopic dissection, using a colleague of mine to retract that muscle retraction site, so allow me to have more access. In the last two more slides, and we finish, Ryan. I can see that we need to run out of time. This is the cecal polyp. We had to perform retroflexion to achieve retraction, and this is the outcome. That polyp took us about 6 hours. It was not an easy one, but that was a great learning curve when we got to know Norio and Yutaka around the team to help us out. Last but not least is the plan is to create a registry in UK and Europe and USA, where we're trying to actually find more about the profile of the device, the performance, and that will include the learning curve, which techniques, the time of the procedure, the outcomes, but more important, we're now looking at the health economics and what are the implications on the patients and service. Thank you. And the last slide is just the Ken course, which you're all invited for this year.
Thank you, Dr. Simolis, for your excellent presentation. We'll quickly move into our video case presentations, starting off with Dr. Fukami. Just a quick reminder for the audience, now is the point where you can ask questions. So on the right-hand side of your screen, you'll see a questions panel. So go ahead and type those in, and we'll log those, and we'll answer as many as we possibly can. But Dr. Fukami, over to you.
Great. Thank you so much. So we learned a lot about the speedboat and the bipolar. And initially, this is you need a therapeutic channel. It's bulky. You don't know how it's going to work. But the cutting actually is fairly impressive. It takes a little time to learn the resistance. So initial start is a little slow, but once you start cutting, it's like a really, without char, it's just cutting through really nicely. We learned, Zach told me that the tunneling method really makes sense. And after doing many cases, I think he made a good comment. I think that would make things much easier, because this bulky device, it's much easier to just create the submucosal tunnel straight without retroflexion. The needle itself is usable, but it's a little clunky. I'm not really familiar in favor of using this needle, but definitely it reduces time to exchange. So when it's needed, it's beneficial. So first, you have to cut into the submucosal space and put a little pressure, just like other needle knife, and then apply electrocautery energy. And you have to go down underneath the submucosa first. Otherwise, it just keep giving the thermal effect on and on. So once you cut through, I found that this angle at the right upper shoulder works best. I think it's reducing the energy. I mean, not that reducing energy. The current density, increasing current density to the right upper edge, make it cutting much easier. So
I think Norio here has a good point, because when you actually cutting to the right, you can see there's no energy delivered on the left. So that really illustrates the contact. So you should be into contact with the tissue before actually press the pedal, and that's why it's a very nice tunnel. I can see you use only the conical hood here, Norio. Is that always your practice to use the conical?
Yeah, initially you don't know how deep you can go, and injection may not be adequate. So opening up the surface slowly is my the safety for colorectal ESD. But once you identify submucosal layer, you have to just jump in, open up, almost like creating the field of pocket for you to get inside the submucosal space. Otherwise, you never get submucosal dissection complete. And I want you to take a look at this fat. You know, in the cecum and ascending colon, you see a lot of fat that creates lots of chars. But the speedboat actually didn't. So that was an additional surprise. This is the benefit of bipolar, I believe. Do you agree, Zach?
Yes, I think it's also apart from the design, because they can actually really focus on the edge of the device or the tip. I think it's also the power. The power is less. Before I mentioned about the soft coagulation, which is about 40 and 80 watts. It's like using similar power to cut the tissue. And that was, I think, was missing from our toolbox, to have a device that actually can cut equally with less energy. And the less energy, I think, has an impact on not only on the patient, because there's no muscle injury, there's no, also on the operator's confidence, because you can be more proactive. You can start. Personally, when I was trained by one of the best ESD masters, I started doing only cases in the rectum, and I've done more than 50, 60, and then there was a point that I wanted to go further to the proximal colon, and I always had this kind of, I was skeptical in case it would be a perforation. I think this kind of technology, I think, will open the mind, will open the box, and then people, they can actually start be more proactive on the proximal colon.
Yep.
If I can we have a question from the audience. Maybe that's a perfect segue. The question is, how many cases does it take to tackle advanced EMR versus ESD in terms of the learning curve? And maybe that's either for you, Zach, or you, Dr. Fakami?
Zach, do you want to comment on it?
I think personally, I believe that whoever can perform a complex EMR, not a simple unblocked dissection, but an EMR under retroflexion, for example, an EMR close to the band, which is really difficult to access. So these people, I think they should have the opportunity to start learning ESD. With this platform, I think there's no actual learning curve. Well, that's why would be the reason of the registry, to try to figure out. But Nori, what do you think about the number? Because it's very risky to mention number now of cases.
Yeah, that's right. Its numbers is really difficult to mention because the technical skill is different. By the way, I'll come back to that. I pointed out with the arrow that with this device, I see lots of kind of coagulated, sealed vessel, kind of donut looking like. It's amazing to see that, because usually the monopolar device kind of obliterate the vessels, but this actually seals off. And I can see that the top is sealed, but the vessel is intact. And I see that many times, so I just wanted to point it out. Once you have a bleeding, you don't have to worry too much because the bleeding is not that severe usually. So you stay around, identify the location, touch it, even near the bleeding site. Then still this microwave coagulation actually works. And again, it's showing that the fatty tissue is being cut without much char or, the vaporization. So this is actually excellent, highly focused energy applied to this submucosal tissue.
We have one more. I'm sorry, Dr. Kami.
Yeah.
We have one more question. The question is, what about this device contributes to the enhanced sense of stability?
Stability is a difficult issue. So, by the way, I'm just seeing the vessel, but I didn't coagulate enough and start cutting, and I should have known. But if you start seeing the bleeding, just stop there, apply microwave coag, and it seals off. So that's another feature that I found is really useful. To answer that question, stability-wise, I felt like I thought it's gonna give me stability. However, if you push it out too much, then you're risking cutting whatever tissue you're not seeing. So I don't know exactly if you're doing more like this, but I'm getting more of a visual cutting than blind cutting. It's much easier to use a 4mm, faster, I mean, but I tend to see more bleeding with this. So I tend to use this more of a stabilized with the cap, using a tip, maybe 2mm at most, and control the vessels and cutting. So
absolutely, Norio. I think the stability is dependent on many factors, but I think as you said, use the cap, the correct position of the scope and the cap together, and then you have to. This device can give you this micro stability when you're on the muscle, so you can lie on the muscle and start cutting on the sweeping on the left or the right hand side. I think I have a video if you can play that very quickly. Which is actually has a lot of fibrosis, which is was very challenging to create a tunnel because some colleagues they might argue that you can always tunnel. I think tunneling is for me now the challenge. If we create a tunnel, regardless if it's a complete or incomplete, I think the succession and the completion rate goes more than 90%. And this tunneling can be a bit tricky if you cannot use the device properly, because if you don't adjust the device on the right size and length outside, then you can, as you said, Norio, you can perforate, you can cut the vessel, and then it will start bleeding. So I prefer to use the device between 2 and 2.5mm, and only in cases where I cannot reach the operation field, but I can see the muscle, then I can protrude the device and I can start cutting. Challenging because I'm using a colonoscope here, Norio, and you know how difficult it is to actually. I couldn't see the lesion with the use of a pediatric colonoscope, so I had to use a colonoscope to actually see the lesion. And I use a ST hood here, conical cut. First is a proximal cut, which is actually I followed your practice. You always do the proximal cut first, and then you go to the distal. Here, this is now the distal part, the anal part of the lesion, which you can see it is on the fold. So I'm trying to create the first mucosal incision, and I struggled. I struggled for 20 minutes to actually find the right plane to do the tunneling. The entire duration of the lesion was 1 hour and 50 minutes, and 20 minutes was actually to open the tunnel. I think. And that's why it's one of these mentality that we should be advocate. That mentality means you have to be patient with the ESD, you have to be very dedicated, and you have to be very committed. When you start an ESD, you're trying to finish the ESD, and not with whatever cost, but you need to be within a time frame. And I did injection. I was trying very gently to use the cap to have a stable platform. Was very challenging, and I can see the fibrosis. I couldn't see any muscle layer, any submucosal. I could see only the muscle layer, and using the trimming of the flap, which is one again of the principles of conventional ESD. And then there's a point which I can just see the submucosal. I can see how far away is the device out, because I couldn't use the scope was too thick, so I had to use a device to create a tunnel. But after that, the whole ESD became very, very slicky, and it was so easy, because as you can see, I can see the vessel, I can coagulate the vessel, pre-coagulate the vessel, and cut the fibrosis here, which is really is a part of fibrosis, without causing any concerns, because you can see where's the muscle layer. So I think one of the main reasons for me to use more and more tunneling is not to lose the orientation, because I can see where's the muscle, I can see where's the polyp, and you see the tunnel, which is really nice. And then use the in to out approach by rotation of the device, and very slow bursts of cut from the center out to the lateral margins. And that, I think there's a point with really that part of the ESD. The beginning was type 3, fun type was really, and then after 10 minutes it became type 1, and I really enjoy, and all the team, all my colleagues, my assistants, and the nurses, they really enjoy that, because the patients, by the way, is under sedation, so they can see on the screen what's happening, which is very, for them, fascinating. Again, the same thing on the left-hand side, and I think we finish now in the next couple of minutes. So yes.
In relation to the question, stability comes from the bottom part. Bottom half is sealed, insulated. It's almost like an insulated bottom knife. So you can touch the bottom, and cutting is happening at the top half. So if you understand that, you feel much safer, right, Zach?
Absolutely, yes. The hull actually provides stability because there's no injury. As you can see here, the muscle layer is intact. There's not even a muscle burn, which is reassuring for the operator and for the patient. Because usually, I don't know what's your practice, we send the patient home on the same day. We keep them for about 4 hours in our recovery, and if there's no post-polypectomy syndrome, which is usually we have only less than 1%, they go home with some kind of antibiotic sometimes. I don't know what's your practice.
Yeah, I do the same. It's usually a same-day procedure. Typically, I call the next day to make sure that the patient is doing okay, but other than that, I don't do admission, except for high-risk patients, cardiopulmonary, renal patients.
Yes.
I do have another question. It says, now that you guys are well versed with the speedboat, what % of the ESD cases do you now use the speedboat in? In all of them? Is it your default gadget?
That's a great question. So, you have to choose your battle. This one requires the adult colonoscope from the Olympus. I think it's Pentax. You can use the pediatric, but so if you're using adult colonoscope, the accessibility is one. I typically assess how easy it is to access. Then I try to do speedboat. It makes me feel much easier. But if there's any complexity to it, sometimes I use stuff from the beginning. I use other monopolar tip knife. So I can't say that it's probably half and half right now, I would say. Zach, do you do all speedboat?
For my side now, I found it very very handy, and I think the more I use the tunneling, because for me the tunneling is a drive to create tunnel. I did try tunneling with other knives; it was not so successful. So, but as you said, one point is the availability, the scope availability, which I use now. Scope with the 3.7. If we can get, let's say, a speedboat in the future that will be slim and go down to a gastroscope, I think that might be a game changer. But then it has to do with the way that you approach the polyp. As you said, tunneling, I think it's not always easy, but most of the cases I think it's been successful. So I would definitely advocate tunneling with the use of the speedboat.
Sounds good. Coming back to the EMR ESD, I think it's a complex EMR is a must technique you should learn,
Yes.
then expand to the ESD, because if you're not be able to do complex high quality EMR, you're not serving the patient. And it has a component of lesion assessment and injection fluid assessing the lifting, and those are things that's very important for ESD as well. So learn the high quality EMR, learn the cognitive part on the lesion assessment, application of endoscopic therapy. Then ESD, if you do adequate number of the animal model, it's much easier to come into the human case. And you have to have a good feedback, how you're doing it, you're ready for it. I think if you ask the tutor or mentor, you can time when to start the clinical case.
I think it's very dynamic, Nora. You're right. It's like after the animal models, which is, a number of cases are adequate, like 5, 10, then you can go to the rectum and they can start doing cases. But it should be supervised. It should be either assisting the mentor, or actually the mentor or the tutor assisting the trainee. So it should be vice versa. It's reciprocal, relation between the two. So it's very dynamic. It should be between the mentor and the trainee. It's very, very important that we should focus on that.
Yep, it's ideal. It may be difficult in United States, but we have to find a way.
Well,
Right?
yeah, I think virtual platforms possibly are today.
One other question we have is, what other types of procedures are you using the speedboat in?
So I know that Zach can mention about the point procedure they performed. I have not done any other procedure than the colorectal ESD with the speedboat because of the size of the tool, and I have to get really familiarized with the technique. And other procedure, I'm so familiar with other tools, and I can complete without much issues. So, Zach?
Yes, I don't have any experience on point, but I've seen experts on point using the speedboat. So I actually witnessed that. And apart from the size of the scope, again, that's one of the main limitations. The main limitation. But if I can change to a slimmer device, I will change. I've seen experts on poem that can perform in poem in 35 minutes. Again, I don't perform personally any poems or any upper GI, so I just can declare what I've seen with my colleagues. It was very, very, very swift and very slicky resections.
Great. Well, I don't think we have time for another video. I believe we're at a little bit over, but I wanted to thank everyone for attending today's webinar, and importantly, I wanted to thank both Dr. Submucosal and Dr. Siamolis for your excellent presentations, and thank you for all the energy and effort you put into putting your presentations together. They were very thorough and highly informative. So we can't thank you enough for that. To those of you who've asked questions we didn't get a chance to get to, we'll certainly respond via email per the email addresses you provided as you registered. I will also provide my contact information out to everybody in case you have interest in attending one of our upcoming training sessions, barring COVID, but we'll have several coming up in the next few months. Lastly, you'll also receive a follow-up email shortly after this that will give you a recording of today's webinar in case you missed any portion of it. So on behalf of Creo Medical and our presenters, thank you for joining us today, and I hope everybody has a great rest of their evening, and thanks again to our excellent presenters.
Thank you very much. Stay safe.
Thank you. Thank you. See you soon. Stay safe.